As a qualitative research methodology, phenomenological research is either descriptive or interpretive, as previously mentioned, and it wishes to study phenomena that are perceived or experienced. The goal of phenomenological research is to arrive at the essence of an experience, and thus providing a unique way to further understand the lived experiences of nurses and patients. This provides an avenue where nursing is studied through the science of caring. Phenomenology generates knowledge that is relevant to nursing practice. This knowledge is attained by sharing common meaning of history, culture, and language. Discovering life worlds of patients is possible with phenomenology. A life world is an experienced world of meanings that includes a person's sense of lived time, space, and relationships with some others. These experiences are linked to social, cultural, and political contexts. In exploring life worlds in research, it is prudent to describe or identify the person's sense of self-identity, the person's sense of embodiment, their relations with others, spatiality in the sense of space, temporality in the sense of time, activities which drive and motivate the person, discourse, and the mood, or the overall emotional personality of the life world. A key value in nursing is to understand our patients' lives and their experiences, and to reflect an empathetic attitude, which parallels with the philosophical underpinnings of phenomenology. In phenomenological research, bracketing is sometimes used, inspired by Edmund Husserl, in attaining an understanding of everyday experiences of our patients with presupposing knowledge. Pain as a symptomatology has been widely used in phenomenological research to guide and change practice. We all know that pain is a complex symptom or experience that is universal to all humans. And healthcare providers' perceptions and attitudes of pain among patients are quite diverse. And hence, it's important to understand that our own values and experiences shape our perception of pain. Now, for instance, if we ourselves or someone close to us had a bad experience with a hip surgery, we may be more sympathetic towards these types of patients as far as their pain levels, as opposed to maybe caring for patients that just had left heart catheterizations. We may not be as sympathetic towards these type of patients because they have, quote, overly expressive experience with pain. And that the evidence tells us that the majority of patients who undergo such procedures may only have mild to moderate pain levels. Of course, professionally and personally, we should have empathy for all patients, but we are nevertheless human and do possess our own values and experiences. We must then be able to recognize that there are different cultures with varying perceptions of pain. A perfect example is the stoicism to pain as being perceived as honorable in certain Native American cultures versus expressive culture of pain among the Hispanic cultures. We all use the "how bad is your pain" on scale of 1 to 10 in practice. It is important to remember that this scale is ordinal in nature and not a ratio scale. Therefore, an 8 out of 10 pain score for one patient cannot be generalized to be the same intensity for all 8 out of 10 pain scores due to the cultures of pain. Pain encompasses various types of pain. Ney divides pain into 4 categories: acute, chronic, cognitive, and emotional. All types of pain are painful. However, there are different methods to treat each type of pain, especially if it is a multi-layered complex paradigm of pain. The treatment is usually broad, and it includes both pharmacological and non-pharmacological techniques. Pain is what the patient says it is a phenomenology-inspired expression that has transformed healthcare. In fact, currently pain is viewed as the fifth vital sign by many because it is often assessed, reassessed, and or evaluated. There's also a strong emphasis among nurses to become fully aware and become sensitive to cultural differences as far as perceptions of pain. Although this is a great focus, but not all pain needs to be treated with narcotics. An example of a patient population that has multi-layered complex forms of all types of pain are certain cystic fibrosis patients post-lung transplantation who frequent the hospital and usually having longer hospital stay. Bearing in mind that pain is already common among adults with cystic fibrosis at baseline. If these post-transplantation patients ever have negative emotional response to pain, their quality of life becomes severely impaired, according to a study by Kellerman. These particular cystic fibrosis patients have an acute or chronic but progressive illness, and some of them may have very poor systems at home. And dealing with these issues, along with the notion that their post-lung transplant life may not meet their expectations of any improvement or any new chance of life even further, may compound or intensify their pain experience. In fact, many of these patients experience intense pain, not just physically, but psychosocially and psychologically as well. Pain control with these patients is very difficult, if not almost impossible. IV narcotics or IV diphenhydramine are frequently requested, but these are only short-term fixes for their complex experience of pain. As a result, narcotic addiction often occurs in these types of patients, which yet adds another layer of complexity to their experience of pain. In using phenomenology-inspired research of individual accounts of pain, nurses can reflect on their own understanding of pain and the patient's responses to pain. This will greatly impact how they recognize, assess, and manage pain, and hopefully promote well-being among patients. Most of the nurses in the lung transplant unit have taken care of these patients for long periods of time because of their tendencies for prolonged hospitalization, and they're very familiar with their family situations, their sleep-wake cycles, their pain complaints, and can even predict what particular treatments really work. So they have developed this routine, the techniques of that may contribute to the overall well-being of these patients on a daily basis, and individualized at that. So when these patients complain of acute pain and are not easily controlled by the usual regimen, or there might be something else more critical that needs further exploration. There are many benefits of using phenomenology in nursing research, one being that the nurse-patient relationship is in constant movement as illness progresses or regresses, and phenomenology accommodates this movement through time in gaining insight of the lived experience, not just objectively in a particular stagnant point in time. Other benefits of phenomenological research is that it leads to more meaningful patient care. It leads to more ethically and experientially sensitive ways of nursing practice. It assists nurses to find meaning in everyday practice from a new and complex perspective. And it contributes to nursing knowledge, as well as ways of knowing, which in turn guides practice. When phenomenological inspired research is utilized, it can provide greater understanding, enhance the performance of the art or the aesthetics of nursing, and promote well being of patients. There are limitations of phenomenological research, and one of the most obvious ones is its broad coverage because it encompasses both a philosophy and a science or research method, as previously mentioned in the other sections. As a matter of fact, in section 3, it talked about the diversity of methods, the multitude of phenomenologists, as well as the various labels that collectively contribute to confusion, hence limitations of phenomenology. Again, this poses as a challenge for novice researchers. There was a literature review involving studies that classified as being phenomenological, and it was found out that there were vast descriptions and labels for the same approach. Again, uh, strengthening the argument that this again contributes to further confusion. Hence, the saying, there is more than one way to skin a cat. Because there are no rules per se in how to conduct phenomenological research, then one might argue that this could contribute to the confusion because of the diversity, the variability within the philosophy. However, this is its Achilles heel because a no rules mentality also gives the researcher freedom and creativity that produces diversity. As discussed in section 3, there are criticisms of phenomenological research. Much of the criticism revolves around the fact that philosophical foundations and our underpinnings are not really adhered to in conducting the research. Finley suggests that it is important to have that firm knowledge base of phenomenology when conducting this particular type of research, and to qualify studies as phenomenologically inspired rather than phenomenologically based if the philosophical foundations are not upheld at all.